So shall I start?
Just 30 seconds more.
Oh,
The moment the streaming happens, I'll just confirm you and then you start. Go ahead, sir.
okay. Thank you so much. Good evening, all friends, colleagues, and my fellow surgeons. Very warm welcome on this evening and for such a important talk on sclerotherapy techniques in hemorrhoids, varicose veins, and ganglion. I welcome you all on behalf of Summer Life Sciences, and on this topic, we have a very senior, eminent speaker, Dr. Sanjay Singla, to guide on this topic. Uh, to just say a few words about Sir, Dr. Sanjay Singla did his MBBS and MS from prestigious Government Medical College, Patiala in 1991 with distinction. He was awarded honorary fellowship of Indian Association of Gastroendosurgeons. His passed fellowship exam of FACRSI. He was awarded travel fellowship to NHS Birmingham, England. He is ATLS instructor with American College of Surgeons and is regular faculty at JPN Apex Trauma Center, AIMS, New Delhi. He is a regular faculty for FACRSI for 6 years now. Speakers at many national symposia for surgery, speakers for Ethicon Surgical Education Program, author to a chapter on endoscopy, and has contributed in various national and international papers. And he is the managing director and consultant at Singla Hospital. So, with all of our heart, I welcome you, sir, and thank you for accepting our invitation. I am sure your lecture will be benefited to all the fellow delegates who have joined. Thank you so much, sir, and over to you.
Thank you so much for the nice words and welcome to all the delegates. Here I share my screen, not taking much of time. And here we go. The topic for today's presentation is sclerotherapy. Sclerotherapy means a therapy which is to cause a sclerosis, means fibrosis. And this can be utilized in many areas of medical science. The commonest are the hemorrhoids, varicose veins, ganglion, even for mucosal polyps of the rectum, anorectum, small areas in children especially, we can use sclerotherapy. The first I take the topic of varicose veins. Varicose veins are abnormally dilated and tortuous veins. Not only dilated, but they should be tortuous also. And they are superficial veins because of the incompetent venous valves, they cause the problem. Most commonly, this condition affects the lower extremities, the legs. If you see, they can be simple flare, there can be small reticular veins as you see on your left side, or they can be dilated varicose veins in the popliteal area as you seen here. Or on the right side of your screen, if you see these are the very dilated vessels, you can see class 3 they call them, and then later on they can have their complications in the form of eczema, pigmentation, C4, and then you can have a healed ulcer or you can have a non-healing ulcer called as C5 or C6 as per the classification of the varicose veins, clinical classification. So there can be different pictures, different presentations of the same disease, but the patient can be in real trouble from aches in the legs, pain, itching, later on ulcers, non-healing ulcers, which is a real problem to manage. Causes can be prolonged standing, aging, and the obesity as such, or any cause which disturbs the negative pressure of the thoracic cavity or the abdominal cavity, which leads to the taking the blood away from the legs back to the heart. Like you can, even a simple COPD can cause increased intrathoracic pressure and can later on present as a varicosity of the veins of the leg. Abdominal tumor, pregnancy. So these are all the primary causes of the veins itself, causing prolonged, because of prolonged stenting, because of the pressure and the gravity. These can, the veins get dilated and then valves becomes incompetent. And initially there is inflammation of the walls of the veins leading on to their dilatation, and then valves becomes incompetent. Primarily the valves are not really damaged. It is present thought is this. But the aging and obesity is such because of immobility of the legs, because the foot pump is not working, if there is some problem with the ankle, and other conditions which decrease the pumping action of the foot. These are all the causes of varicose veins. And surgeons also come in this because of prolonged standing can be because of this man who is in the bus as a conductor, or even the surgeons are at risk, and even the vendors, hawkers, whosoever has a prolonged standing hours can be at risk. Pathology is due to the valve's incompetence in the deep or the superficial veins, and the valve doesn't close properly, which leads to dilatation of the veins, and after some time they become tortuous and twisted. You can see here in this slide the blood flowing in one direction like this, and these are the valves and the cusps. When the blood comes back, these cusps close and the blood cannot come back. So in the human body, there are superficial venous system and the deep venous system. From the blood goes from superficial venous system to the deep venous system, and from the deep venous system, it goes to the inferior vena cava and up to the right atrium. Now the problem comes when the perforators, which are the joining columns between the superficial venous system and the deep venous system, and is as such in the superficial venous system, when these cusps are damaged because of some swelling in the veins as such. Now what is happening? These cusps do not close and the blood comes back. And this leads to the dilatation of the blood vessels and tortuosity, causing on the varicose veins. You see here, the blood is coming back. These muscle pumps, they are helping the blood to go up. But when these valves are damaged, these vessels get twisted and lead on to the varicosities. So basically you have to have an intact program of the whole body, means a negative intrathoracic pressure and the pumping action of the soleus muscles and the ankle movement. Everything is important. So, and the normal, there should be a flow in the deep veins. If the deep veins are blocked, if there is a deep vein thrombosis, it leads to secondary problem of the superficial veins. Because if the deep veins are not working, if there is a thrombosis because of any inflammation after the pregnancy due to sepsis, varicose triad, as they say, there's inflammation of the veins, or there is an increased viscosity of the blood, anything which can cause damage to the endothelium of the veins, it leads to the deep vein thrombosis. And when there is a deep vein thrombosis, the superficial veins cannot empty into the deep veins. Again, there is a problem, and that leads to secondary sort of veins. And one should be very clear about that. Before giving any treatment to the superficial veins, the deep veins should be patent. If the deep veins are not patent, then it's a problem. Symptoms can be pain, heavy legs, appearance of spider veins, dark discoloration of the skin, and itching. They are the problems. Like in this slide, you see the spider veins. And when the varicose veins are there, there's a chronic venous insufficiency because of the pooling of the blood, the iron, hemosiderin, and these things, they come out, leading on to sclerosis. First of all, there's a fat and the skin, they get infected, they get inflamed in the area, and leading on to sclerosis of even the skin itself. There may be patches, white patches, and the skin can be too tight near the malleolus, leading on to ulcers, and then ulcers not heal. So these are all the complications of the chronic venous insufficiency which can take place. Thereby, the treatment is very, very important. In today's medical practice, what should be the first investigation to define the area of varicose veins? So the most important thing is duplex ultrasound scanning. Gone are the days of simple tourniquet tests or the hand Doppler. Nowadays, we should do a duplex ultrasound scanning, and should be done by a dedicated vascular person who is going to treat the person, not by the radiologist only, but by a person who is going to treat, because only then the proper mapping can be done. And you can see the dedication of this fellow, how he is kneeling and doing this mapping with the help of a duplex ultrasound scanning. And this picture has been taken from the most loved book in the surgery, Love and Belly. To see the presence of reflux, this is very important. Then exact distribution of the leakage points, that wherever there are perforators, maybe at the great saphenous vein and saphenofemoral junction, or in between in the thigh there are perforators, or the perforators below the ankle in the soleus area. And you have to also check the status of the deep venous as well as the superficial venous system. Because if there's any thrombus in the superficial venous system or in the deep venous system, probably the treatment will change. Suitability of the refluxing veins for different treatment modalities is also checked by this duplex ultrasound, because you have to check the size and the tortuosity of the vessel, because there are certain procedures which cannot be done in very tortuous vessels. So that's why you have to find out the size of the vessel, maybe 1 millimeter, maybe 3 millimeter. So accordingly, you have to select the instruments which will go into the veins. And then you have to also find out the pelvic organs. If there is any pelvic organ problem, there is maybe increased intra-abdominal pressure and compression over the veins, it can cause problem. So this is why the first investigation has to be a duplex ultrasound scanning to map the veins, to find the conditions of the veins, and to find the right type of instruments to treatment of the veins. Now, what are the indications of this sclerotherapy? Sclerotherapy is reserved for uncomplicated primary varicose veins or recurrent or the residual varicose veins following surgery, spider veins of the lower extremities, and also in the treatment of ganglion you will see. But the problem is, one problem is that there are papers to tell us now that there's a difference between the ultrasound guided foam sclerotherapy and the two other treatments, like in the form of surgery and the endovascular laser ablation. And they found that after 1 year, the recanalization after sclerotherapy was much more, 19%, as compared to other two modalities of endovascular laser ablation and surgery. So therefore, for major vessels, like for great saphenous vein, for popliteal vein, most of the people now reserve that for EVLA, means endovascular laser ablation, while the areas where you cannot do endovascular laser ablation, like the veins below the knee on the greater saphenous system, because the saphenous nerve is going very nearby that, and by using laser you can injure that. And those are the areas where you can do ultrasound guided this foam sclerotherapy. That is the best for that. For all perforators, you can do ultrasound guided foam sclerotherapy. So these are the areas where you can do that. And after recurrence, suppose you have done a EVLA and you find a small recurrence, you can do a sclerotherapy in the office. Because there are certain advantages also of the ultrasound guided foam sclerotherapy. And those advantages are that it avoids tumescent anesthetic and is therefore a less painful procedure. What is tumescent anesthetic? Whenever you give endovascular laser ablation treatment, you have to give a lot of fluids and anesthetic agent into around the vein, so that vein gets separated from the nerves, and the vein gets compressed also when you put a laser fiber inside. So, but here you don't need any of this tumescent anesthetic, and no tributary vein is that tortuous that you cannot give a sclerotherapy. But if the tortuosity is more, you cannot do RFA or a laser even. And it also allows the treatment of calf veins with overlying skin damage. Even if the skin damage is there, but because you have to enter from somewhere else, so there is no need to enter the pierce the damaged skin. So you can still do a sclerotherapy, and the consumable treatment cost is very, very low. So those surgeons who are doing endothermal techniques also, they still have the sclerotherapy as an adjunct in specific circumstances. So the sclerotherapy can be used as an adjunct as well as treatment of those varicose veins where you do not want to do endovascular laser ablation or a thermal ablation. If you remember our old days of doing surgery, we used to ligate, flush ligation of the great saphenous vein with the femoral vein, and uh, and we used to then strip it off up to the knee, not below the knee. So whatever we were doing by surgery, you can do it by a endovascular laser ablation, and where we were doing only those perforator ligation and other things, there you can apply the sclerosing agent, as well as small flares, reticular veins, you can do sclerosing agent even for cosmetic reasons also. The only problem is that if the person have anaphylaxis to any of these agents. Now, how to do this sclerotherapy? What is a sclerotherapy? A procedure that involves an injection of a distinct pharmaceutical agent, also known as a sclerosant, into the allied veins. But before you start sclerotherapy, you have to have a good Duplex study, I have told you, and because the anatomy is here with different patients have different anatomy. Anatomy is very peculiar to the varicose veins. There can be a lot of anatomical variations. So on this forum, on this lecture, we cannot define everything. How it works? Now the sclerosant. Sclerosants are basically irritants which injures the endothelial surface of the vein, causing it to collapse. How? By inflammation of the endothelial lining. Later on, occlusion and the blockage of the injected vein, formation of the fibrous tissue, and leading on to partial or the complete vein collapse. The only thing is that blood will cause dilution of the sclerosant agent. So you have to milk away the blood. When you are using a sclerosant, you have to milk away the blood from the vessel, and then compress the vessel with the help of ultrasonic probe itself or with the massage. You can do that. I will show you how we do that. What are the different types of sclerosants we can use? So there are detergents which disrupt the vein cellular membrane. They are the sodium tetradecyl sulfate and polidocanol. Certain osmotic agents like hypertonic sodium chloride, sodium chlorine solution with dextrose, or certain chemical irritants which can direct caustic destruction of the endothelium like polyiodinated iodine. The commonly used one agents are the sodium tetradecyl sulfate and polidocanol. And out of that, sodium tetradecyl sulfate is commonly used for varicose veins, and polidocanol is commonly being used for hemorrhoids. The most commonly used agents they include thereby sodium tetradecyl sulfate and polidocanol. Advantages of these two agents: absence of pain with intravascular injection, though minimal pain can be there, very low incidence of allergic reactions, there's no hemolysis, and lesser hyperpigmentation because of these agents. Sodium tetradecyl sulfate, 3%, present as a 2 ml ampule. You can have 2 ampules maybe there in one pack, and then you are to use either direct or with a foam. Nowadays, we use it as a foam because that increases the surface area. So with the same dose, with the minimum dose, you increase the surface contact area of the surface. So thereby increasing the efficacy of the drug. It's a FDA approved sclerosant. There's a high occlusion rate of 94%, reliable, safe, and effective. Treatment time is shorter and recovery is faster, reduces the cost and morbidity associated with surgery. That's why you can use sodium tetradecyl sulfate. And the product manual or the product prescription which comes with the this drug is very important, and that is really very good information available. I have even pasted this page into my book. So whenever I go through this literature also produced by this set with the Cetrol, and they have given all your indications, contraindications, the anaphylaxis and other things, other complications, other precautions you should take, and this is a good source. Mechanism of action, if you see, there's the inflammation of the endothelial lining, which leads to occlusion of the injected vein, formation of the fibrous tissue, and partial or a complete vein collapse thereby. The dosage, you can treat it either as a liquid or as a sclerosant with the air mixture. 0.5 to 1 ml at one site is good enough, not more than 4 sites to be injected. So in any case, not more than 4 ml at all. Most of the time, the 0.5 ml works. And for the formation of the foam, you can use it with the air. You can create a foam in 1:3 ratio or 1:4 ratio. That's fine. And I will show you how to make that foam. If this is a Tessari developed this technique, and you have to have a 3-way tap and a 10 ml syringes and 21 gauge needle. Draw the 2 ml of the liquid sclerosant into 10 ml syringe and 8 ml of air into the another syringe. Connect both syringes to a medical 3-way trap. Move the plungers of the both syringes back and forth for 20 times to produce closing foam. And when you use this closing foam, it remains stable for 2 minutes at least, and you can inject it. We'll show you the video and we'll be describing about the piles, how to make this sclerosing agent foam. So this is the technique you can see. In the figure 1, they have taken the liquid and now they are started mixing, and the foam is created in the figure 4. After that, almost even the one person is making foam, the other person, the surgeon himself, the person who is doing the procedure, position and vessel with the help of ultrasound guide. Depending upon the size of the vessel, you can cannulate the those vessels where you are to put the drug. And after that, those cannulas you can put, you can use a butterfly cannulas, or you can use Venflon, depending on the size which is available to you, with the help of ultrasound probe. And here you can see the USG guidance. The probe is inside, even for the laser technique. Here, video, Ravindal, who is working in Mohali hospital, that how to do this. You can see that the doctor is now using equations as well as detecting the this probe, 7.5 to 13.5 megahertz probe, already marked varicosities and injecting the drug. You have seen that. This is how it is done, and then the compression is done. And if you see it on the monitor, you will find that there is a black area, black halo under the skin, and that is the vein which we are scanning under the ultrasound. And when we start injecting the drug, you will find out that the foam will come to this place. Once the foam comes to this place, now you see the foam has come to this place, and now we are slowly injecting the the help of the probe itself area. What to do the post procedure care? Compression bandaging is to be done. Everybody recommends that. Some recommend for a week, then other for the 3 weeks, and some recommend that initial 3 days you give it whole 24 hours, and then after on during the day only, limb elevation, and they promote walking as early as possible. And the complications can be, if there is any anaphylaxis, you have to be careful. There should be everything available to deal with the anaphylaxis, and you can at times people even inject 0.5 ml and wait for 1 or 2 hours, and if there is any anaphylaxis, then they don't do the procedure, or then otherwise they do. So this is all, though the rate of anaphylaxis is low, but still it is possible. Even it is possible that you can have an air embolism and other things. The literature provided by the manufacturer should be taken care of, and a proper consent should be taken before you do this procedure. So now I hand over the mic for a small questions or the quiz to the Mr.
Okay,
Vishal.
so we'll just have a quiz, small quiz on varicose veins. Okay, can you see the question?
I read out the question.
Okay.
Based on efficacy, in order of sequence, you will offer your patients of venous hypertension of the legs. A is EVLA, then radiofrequency ablation, and then ultrasound guided foam sclerotherapy. A response, first is EVLA, second is radiofrequency ablation, and third is ultrasound guided foam sclerotherapy. The B response has ultrasound guided foam sclerotherapy as the first response, EVLA as the second response, and radiofrequency ablation as the third response. And the C has radiofrequency as the first response, EVLA has the second response, and radiofrequency ablation, sclerotherapy has the third response. You have to tell in order of the sequence that whether you will have this A or a B or a C.
So I think mostly people are going with option.
I think they are still voting. You can give another 30 seconds for that. We'll give 2 minutes.
Yes, sir. We'll wait for another 30 seconds.
Yeah.
So I'll just end it.
Yeah. So the answer is the A response, means the best is results are with endovascular laser ablation. The second best is with radiofrequency ablation, and third is the ultrasound guided foam sclerotherapy. And where you cannot do any of these techniques, then surgery comes the next.
I'll share the next
So
question.
please have the second question.
Yeah.
So the 48%, those who have voted for EVLA as a first response, that is okay. So the question number 2. In modern day practice of varicose vein treatment, which is the best way to investigate in the beginning? A tourniquet test, a handheld Doppler, or a duplex ultrasound study with 3.5 to 13.5 megahertz linear probe.
Most of the people have voted for C option.
That's correct. In modern day practice, gone are the days for tourniquet tests, though you can do still in clinics, but you cannot reliable 100% on them because a lot of more information is required for endovascular techniques. And the duplex ultrasound studies is the best way, and most of 96% of the people have voted for that. It's great, wonderful. Next question, please. Question 3. Sclerotherapy for the veins should not be done in case of active venous ulcers, tortuous veins, venous flare and reticular veins, DVT and thrombophlebitis of superficial veins. Okay, they can be used in active venous ulcers, no problem. Tortuous veins, yeah, they can be used because you can just inject them. Venous flare and reticular veins, for cosmetic reasons, we do that. Yes, 90% of the people have voted against the DVT and thrombophlebitis. Very true. You cannot treat the superficial veins if the deep veins are already thrombosed or there is any active thrombophlebitis in the superficial veins. Next question, please.
Okay, sir. So last question.
Which one is not the complication of foam sclerotherapy? Extravasation, air embolism, diphasic anaphylaxis, all of the above, and none of the above.
I'll just
Okay. Extravasation is a possible complication. Air embolism is also a possible complication of foam sclerotherapy. Diphasic anaphylaxis means when the patient has one anaphylactic reaction, gets relieved of that, and after 30, 40, 50 minutes or 1 hour, has another episode of anaphylaxis reaction. That is called as diphasic anaphylaxis. And this has been recently reported in September itself, 2020, in one good journal with polidocanol. It can happen with any drug. So this is called as diphasic anaphylaxis. And all these above, A, B, C, all these above are possible complications of the foam sclerotherapy. So then which one is not? None of the above. None of the above is the answer, because all the above, they are the possible complications of the foam sclerotherapy. Thank you so much for sharing with us this pool, for voting for these questions, for the participating in the quiz. Thank you so much. We move on to the next topic, that is dealing the ganglion with sclerotherapy. So can I start with the ganglion?
Yes, sir. Yes, sir.
Yeah. A ganglion is a cyst, which is a fluid-filled swelling that usually develops near a joint, most commonly near the wrist. Exact cause is unknown, maybe trauma, maybe some mechanical stress because of the manipulation of the tendons around. There is synovial fluid between the joints, we all know, which allows the smooth movements. Because of the trauma or the mechanical stress, there is increase in the synovial fluid production, and this fluid leaks out and gets collected in a sac outside. That is called as a ganglion. A generally painless condition, but can be painful with a bigger size. If it increases in size, it may compress the nerves and other tissues. And for cosmetic reasons also, and because out of fear also, the people present with this complaint. Sodium tetradecyl sulfate causes obliteration of the cyst cavity, preventing further accumulation of the fluid inside the cyst, and this is one of the ways how to manage it. After injecting local anesthetic agent around the ganglion, aspirate the content of the sac with the help of a 19 gauge needle with 10 ml syringe. Mind it, it should be 19 gauge, a wide bore needle, otherwise the aspiration will become difficult. Remove the syringe, but keep the needle in situ. Then you can put 0.25 ml injected if the aspirate is less than 1 ml. But if the aspirate was more than 1 ml, you can inject 0.5 ml of the STS. Then you can apply a dressing and bandaging. Patient is reviewed after 6 weeks and 3 months. Aspiration is repeated if required. A simple way to manage ganglion, no surgery. Results: sodium tetradecyl sulfate is an effective sclerosing agent after aspiration of the wrist ganglion, with an excellent short-term efficacy and a long-term cure rate comparable to that of surgical excision, as you find in this paper. Coming on to the next topic, that is the hemorrhoids, commonly called as piles in English literature also, because the pile I mean ball. But in India, we call it as bawasir. And till date, I have not been able to find out from many of my friends also. In the last lecture also, I asked them, anybody knows why it is called as bawasir? If anybody knows, please share with me too. The hemorrhoids are not disease. Hemorrhoids are the normal vascular cushion in the submucosa of the anal canal, as you see here. It is in after above the dentate line. Here is the mucosa. Here is this is the anoderm, where it is tightly closed. There is no submucosa here. But here there is a mucosa and then submucosa, and in the submucosa you have certain vascular cushions which are devoid of their muscular wall. That's why they are called as sinusoids. There are pre-vascular sinusoids in the form of capillaries or the arterioles, which come and then they form a sinusoid, and after the sinusoid they form the venules, and the venules they go back, the blood goes back. But if these sinusoids get engorged, and they may bleed, and the bleeding is easy because they don't have any smooth muscle wall outside them, and when because of the straining, because of that, they prolapse outside the anal canal. Because the ligaments, the Treats ligament, which are there to support, they're called the skeletal, they're the conjoint ligament, it gets broken with the age, with the straining, and this mass then prolapse outside and leading on to increase in the grading of the hemorrhoids. Causes can be low fiber diet, or dietary or defecatory habits. We have to recommend the patient to change them. A low fiber diet leading on to constipation and then straining at stool, and then long sitting hours in the toilet. Nowadays, people seeing their Facebook, Instagram, and this WhatsApp and all everything in the toilet is very bad habit, and we should avoid that. Straining and constipation can be another reason for that. And any cause of increase in intra-abdominal pressure because of pregnancy, and then degeneration because of aging. And probably we are paying the price of standing on 2 legs, because hemorrhoids are seen either in human beings or some old dogs who remain sitting. No other animal have hemorrhoids. There are two types of hemorrhoids, external and internal hemorrhoids. External hemorrhoids, they occur around the anus. They're out of in the enoderm area and out in the skin area. This is the place of external hemorrhoids. This is the place for internal hemorrhoids, and when they engorge, they become enlarged, they can prolapse outside. You have to differentiate them, important, because you can only inject the internal hemorrhoids. You should never give any sclerosing agent into the external hemorrhoids. Internal hemorrhoids, they occur inside the anorectum. They are generally painless bleeding. They can complicate into prolapse or strangulated hemorrhoids, and will come in the due course that where we should inject and where we should not. If we see the grading, which is usually the Goliath grading, if there is no prolapse, but there is a just prominent blood vessel, this is grade 1. If there is a small prolapse into the anoscope, as well as when the patient bears down or does a Valsura maneuver, they come out, but spontaneously they go back. That is grade 2. When they come out, but they cannot go spontaneously out, you have to manually reduce them. They are called as grade 3, and grade 4 are when they are permanently outside. You cannot even put them back spontaneously. If you see the American Society of Colorectal Surgeons clinical guidelines, you again have the same. If you have a prominent hemorrhoidal vessel, there is no prolapse with valsula, but spontaneous reduction is grade 2. Grade 3 is when manual reduction is required, and grade 4 is when chronically prolapsed manual reduction is ineffective. This classification is important to understand, because office procedures can be done or are usually useful in 1 and 2 condition. In 3 and 4, usually we may have to resort to some surgical maneuver. But now with the changing trends, you will see in the coming slides that even certain grade 3 piles also can be treated with sclerotherapy. We'll see that. Now, if you see the guidelines, the office procedures like rubber band ligation, the sclerotherapy, the infrared coagulation, etc., they have good with rubber band ligation at the maximum. But the sclerotherapy, even with the help of Alta or some other, we can achieve up to 88%. Usually with the phenol in almond oil, the results are usually 70%, 66 to 70%. And with increasing time, the results decrease. But they have a very strong recommendation of 1A in the early symptomatic hemorrhoids of grade 1 and grade 2. One precaution: if the person has any urinary retention after the technique, or there is increase in pain and fever, you should be very, very cautious, as these may be the signs of undergoing severe sepsis after any office procedure. So if a person complains of these, you should be cautious and you should take the immediate steps of examining the patient. So this is a word of caution before we further proceed. Before you do the sclerotherapy, you should know the agent which you are using. You may use 5% quinine urohydrochloride, not very commonly used. Sodium tetradicyl sulfate, 2 to 4 ml with 1%. Or 5% phenol almond oil or a vegetable oil can be used. Hypotonic saline, sodium morphate. And you can use polidocanol, we will come later on. Aluminium potassium sulfate, called as OC108 in China. You can use from 9 to 13 ml, or the Alta in Japan. Sclerotherapy, which was invented by the Morgan, basically started by Morgan and then popularized by Mitchell. The results can be up to 88% if done properly. For grade and grade 1, 2 hemorrhoids, you can use phenol, vegetable, urea hydrochloride. If you've seen 5% phenol element is the commonly used agent over the years. My professor taught me this at Medical College Patiala. He was running at Government Medical College Amritsar. He was running a clinic for the piles. Professor Amarjit Singh sir. And we basically were using 5% phenol. Still we are using, and we're using for almost 28 years. I've used that, and still we are using at places. 5% phenol in almond oil, 1% sodium tetradicyl sulfate, polidocanol, Alta, and microfine purified fractionated fibroids. Flavonoid fractions have also been used, not as a sclerotherapy agent, but as injecting into the piles to stop the bleeding. Where it is done, it is injected in submucosa around the pedicle. As you can see, around the pedicle, you are injecting in the submucosa, which will lead to formation some edema, some inflammatory reaction, intravascular thrombosis also. This inflammation or this edema will later on lead into submucosal fibrosis and scarring, which will fix this tissue to the underlying submucosal tissue to the underlying musculature. It minimizes the extent of mucosal prolapse also, and potentially shrinks the hemorrhoids as well. The procedure is very quick. It should be painless. You can follow the patient after 6 weeks, and you can again do the injections. 2 to 3 further injections may be required at times, and free from major complications. But there are certain complications. The commonest complication I have seen is the pain in the epigastrium, or as a vasovagal reaction. You should ask the patient to lie down and check his oxygenation level and if and the pulse rate. If there is any bradycardia, you can take the help of your colleague also who is standing by side, and you can manage the patient. Always ask the patient to lie down, raise his limbs, and give him oxygen. They improve. Contraindications can be prolapsed piles and infection. You should never ever inject into a prolapsed pile or infection of a strangulated pile. But the other complications, which are not in the office, but you will see later on, they can be the excessive inflammatory response. There can be a very high inflammatory response, and when the patient comes for the follow-up and you do the digital rectal examination, instead of 3 columns of induration, you will see the all around there is inflammation, and that is a problem. Sometimes can lead to a lot of scarring and stenosis. There can be secondary hemorrhage due to the mucosal necrosis if injection is given in some mucosa. I tell you, this is the submucosa here, and this is the mucosal layer. If your needle is very close to the mucosa and you have infiltrated here, there will be sudden blanching and complete whiteness of the mucosa. If that happens, that means you are in the mucosa, not in the submucosa, and later on that mucosa may slough, leading on to secondary hemorrhage. So your place should be in the submucosa, not on the mucosal lining. So this is important. Retroperitoneal sepsis can be there if you are too deep. You can go into the muscles also. Sometimes portal pyemia and necrotizing fasciitis can be there even. Prostatitis and impotence. If you are applied anterior pile in the anterior pile, you have gone into the around the urethra. There can be some, or in the small vesicle area, there can be problem. And you will see in my video that why we want to do then a digital rectal examination beforehand to find out what is the protuberance of the prostate also before we inject the piles. Or if you are too negligent, you can have a rectovaginal fistula in the female with the anterior injection. What are the recent changes in sclerotherapy for improving the outcomes? We're using all the 5% phenol in almond oil. Now, there are two things that come up. The use of the foam of polydocanol, 2 cc polydocanol with 8 cc air, total 10 cc, or a 4 cc polydocanol with 16 cc air mixed by Tessari method to make a foam. We'll show you how to make a foam. Or the second other agent which is available is the aluminium potassium sulfate with tannic acid, used extensively in Japan and is recommended for grade 3 hemorrhoids. They have done almost in 3 lakh patients, they have shown the results and they're happy using this agent. Probably the technique, I will show you how they do the ALTA, and probably the technique matters more. Polydocanol 3%, 2 ml ampule comes. You can use it with 1:4 ratio with the air, making a 10 cc foam and then can inject in all your piles. Is a sclerosing agent for intravenous use also. So for the first degree and the early second degree hemorrhoids, needle was inserted into 1 to 2 centimeter deep, parallel to the anal canal. You should not be deep and you should not be very superficial also with the needle tip. About 2 ml of polydocanol was injected slowly, allowed time for dispersion in the tissues. You can do the massage also. The needle was held in place for about 2 minutes and then slowly withdrawn to facilitate the sealing of the tract. This was recommended in the Surgery Journal and Journal of Evolution of Medical and Dental Sciences with good results. And they found that 89.66% patients had satisfactory results, but the prolapse component increases and the bleeding also and the 1 or the second year follow-up therapy. So polydocanol is an effective sclerosant for the treatment of early hemorrhoids. Recently, in the Portuguese gastrointestinal surgeon, there is, and this by Lokesh Kulshetra also, this study is there. And this is another journal in 2018, they have shown that polydocanol foam injected at high doses with intravenous needle. They say there's an almost perfect treatment for symptomatic internal hemorrhoids. And the efficacy was very high out of the 1957 patients. And the 92% patients with mild or no pain is well tolerated. And they have a few problems like 2 cases of rectal abscess, 8 cases of thrombosis, and 1 urinary retention. The conclusion was that the treatment of internal hemorrhoids with polydocanol foam injected in high doses is very effective and safe for the control of blood loss and prolapse in patients and anticoagulants and antiplatelet treatment. So the same we have shown in these slides also to highlight that the patients, the effective results was in 98%, 92% have no pain, and 86% the prolapse volume was reduced, and it was well tolerated. And conclusion is it can be used as a good treatment modality, almost perfect treatment for hemorrhoids. The another agent is ALTA, which is aluminium potassium sulfate and tannic acid injection for hemorrhoids, used in Korea, in China, in Japan. And this causes again inflammatory response with fibrosis, and it causes better response than phenyl in almond oil. This was proved by the study. And the Alta injection is considered to have more lasting effects than phenyl. This is in almond oil injection and to be effective for the treatment of grade 3 and 4 hemorrhoids. So they found that this is a better response than phenyl injection. And using Alta in a 4-step injection technique, which I will show you in the next slide, a treatment outcome similar to those of a radical hemorrhoidectomy. That is what this paper says. I think a little over enthusiastic paper, but still, because I personally, this sort is not available in our area, in our country. And if anybody knows where, if it is available in the country, please let me know also. Alta has a potassium aluminum sulfate and tannic acid at its main components. It was called OC108 after changing some substances in zeoxylin, which was invented in China. Later, it was on sale under the name of Zeon in Japan and Korea. So this is a history, whatever I know about this Alta and how they give it. This is the show that how they give it in this journal of the Korean Society of Coloproctology, that they make 4 points. The first is superior rectal artery area, they inject 3 ml of it. They inject about 9 to 13 ml. And then into the 2 ml, they inject into this submucosa. And there in the muscularis mucosa itself, they inject here around in this in this mucosal area. So this is very deep into it, and there in the just in the submucosa they inject about 2 ml, and at the lower end of it they again inject 3 ml. So in total they almost inject 3 ml, 3 ml, 6 ml, 2 ml, 8 ml, and 1 ml, 9 ml. So almost 9 to 13 ml they inject into the one pile mass, and I find that probably the technique itself has also to do something with better results, because now they are inducing, giving sclerosing agent in almost whole of the area of the piles. We earlier were using to just in this area, we were giving in the submucosa and injecting all the piles. The beauty is that you can inject all the 3 hemorrhoids with this technique also. And this is how they inject the 4-step injection of Alta. They have shown in their literature, and this is effective. A trick of the trade. Regardless of which sclerosing solution is used, we practitioners must be conscious of the differences in dose and the inflammatory response unique to each. And the second thing is that it is appropriately placed injection. That is the key step to the successful, safe sclerotherapy for the bleeding internal hemorrhoids than the agent as such. But with the Alta, they have shown that they have even treated grade 4 piles. And we personally have no, honestly, any exposure to that agent. Now, I will show you small videos that how you do a pre-procedure digital rectal examination. Here you see, as we go, that you are not to poke your finger, you have to lubricate the perineal area and the inner area gently, and then you should be doing it for a pretty 1 or minute, and you should never poke like this. You should always put the finger on the anal verge posteriorly and let it slip inside slowly, slip inside. And when it slips inside, there should be no pain to the patient. It should be very gentle. You should do the full examination, going to the sacral hollow, seeing any abnormality, going on the one side, on the right side of the patient, going left side of the patient, and then going anteriorly. You should find out how much is the prostate bulge in a male, because when you put a proctoscope, you may cause damage to the mucosa if you don't know where to go to the proctoscope, and you can inject into the small vesicle or the periprostatic area also if you don't know how much bulge of the prostate is there. And when you remove your finger, you have to again find out whether there is anything in the lumen and if there is anything on the finger star. So this is, you should do a very gentle digital rectal examination before you go for this. The material required is that if you are using almond oil, you can make this almond oil phenol combination because it is not available in the market as such. But 100 cc almond oil is available, badam rogan with the dabur, with hamdard, and you can put it in this, as I use in my clinic, I put it in a jar like this and put 5 ml phenol into 100 cc almond oil. Then I put it on this jar. This is the beauty. You can put it directly on the flame. It's a scientific calibration jar, and you can boil it for sterilization. And whenever you have to do the procedure, you can just put it again on the flame and you can store it with a cover. You can use a Gabriel syringe. Nowadays, it is not that commonly available. It was marked only 3 cc also, so that you don't inject more than that. Nowadays, disposable Gabriel syringes are also available. These needles are also available with some surgical companies. I have these 2 needles, one curved and one straight. Or you can use a 20 gauge spinal needle also, and you can slightly bend it from the front so that angulation is good. So this is what is material required. to make the solution, and how you can, or you can use your this polidocanol. I will show you how to make a foam for that. And universal precautions and safety and equipment, which I will show in this video. You have to take all the universal precautions of bloodborne diseases or other things, that even in the COVID-19 era, you may have to use the mask, your face shield also, so that there is no splash. As you go here, we're using double gloves here, again for the precaution sake, and the surgical gloves, the sterile gloves we are using here. And after the wearing the surgical gloves, as this film I just made in this COVID-19 time, so I will show you that how I am using the face shield also, so that after the mask, so that there is no splash while doing. And this is what is required here. You need these gauze swabs. You need this proctoscope. You may use a beveled proctoscope also. You may use a well-fitting proctoscope also. You can use a self-illuminating proctoscope also. You need few gauze pieces, good some wet with the saline, a forceps so that if there is any bleeding, a spinal needle, and sterile. You can slightly bend. Be careful. Here you can injure. I will show you here how it can injure your gloves and your finger also. So you should be careful. If at all there is an injury, you should be careful. You can change your gloves also. So you can use a needle holder also to do that. And how I will show you here that how we go to make foam by the Tessari method. Make a foam.
We take 2 syringes, one 3-way, and put 4 cc of.
Or 2 cc or 4 cc. I have taken here 2 cc.
And then start mixing. 2 cc
agent we are using this time.
The rest is the 8 cc. Here we are making 1 and 4.
1 into 4. We are using polidocanol here, and this is how your assistant can create a foam for you. Vigorously, they have to do it for 10 to 20 minutes, 10 to 20 times. And after that, a foam is created. And this foam remains stable for 2 minutes. And after
We do this, and this will remain stable for at least
2 minutes. And after you have made this foam, now you have to gently take the one syringe and out of this, because it will increase the surface area. This foam increases surface area, and those remain same, but you increase the surface area of contact. So that is the importance of making a foam. And after this foam have been, now the good amount of foam has been created, it will be stable for 2 minutes. And now we can remove this one syringe, and we can take this syringe, apply a needle over it, and then we can inject. Now for injection, I just did what happened. You have to clean, you have to put on a proctoscope and then clean it, and see when you withdraw the proctoscope, you will see the hemorrhoids. Always inject the hemorrhoid, which is, if in a lithotomy position, as at the 3 o'clock position, means the hemorrhoid which is at now at the base. Because if we will inject the hemorrhoid at the top, if it bleeds, it will cause a problem when we inject the base. So first inject the hemorrhoid at a 3 o'clock position. In this case, the lowest one. Then at 11 o'clock position, then at 7 o'clock position, as if the patient is in lithotomy condition. So here, we will be injecting first the right lateral pile mass, then left lateral anterior, then left lateral posterior. First at 3 o'clock, then at 11 o'clock, then at 7 o'clock. Thereby, if there is a bleeding, it will not hamper you injecting the further tissues. You inject, slightly aspirate, it should not be directly into the bloodstream. And then now you see the changing of the color of the mucosa.
You can see the change in color of the
Mucosa, you can see it has slightly white, it has started happening in the submucosa we are injecting, and it has increased the mass of the hemorrhoidal tissue also. And after that, if there is a bleeding like this, you should put a finger inside. You can massage also over the pile mass so that you diffusely distribute the area. And after that, if there's a bleeding like this, you can just put a small saline soaked gauze over it, press it for a minute or two, and it will stop. So this bleeding stops. Final inspection should be done. There should not be any major bleeding, or there should not be anything, any gauze, etc. should be left inside. Unnecessary, it will cause patient reaction of that to the patient. So after that, you can give the patient metronidazole You can ask the patient to lie down for a few minutes because there may be any vasovagal reaction. And you should call the patient if there is any problem like any pain, any increase in fever, or any appearance of fever, or if there is any bleeding. Otherwise, after 3 weeks, you should examine, and after 6 or 8 weeks, if you required, you may inject the varices again. Hemorrhoids again if required. So with this, I close this, but we will first go for a quiz
Yes.
for this hemorrhoids, and I hand over to Mr. Vishal for that.
Yes, sir. Yeah. So first question, sir, you can.
Yeah. The first question is, following is the best indication for sclerotherapy in piles. The first response is grade 2 piles symptoms not relieved by conservative methods. Grade 3 piles, grade 1 piles asymptomatic now, and strangulated piles. So, which is the best indication for sclerotherapy in hemorrhoids? Okay, we also go with the audience poll because the grade 2 pile symptoms not relieved by conservative method is the best indication for sclerotherapy out of these four. You should never inject into the strangulated piles any sclerosing agent. Grade 1 piles who are asymptomatic now, they are being best managed with your dietary and defecatory habits, need not any injection. And grade 3 piles, if you are using the sclerosing agents like we have already discussed, the results are not that good as with other procedures like lasers, like stapler or open surgery. So depending upon your expertise and what is available in your area, you can treat your grade 3 piles. But sclerotherapy, though Alta has shown some promise, but out of these four, the best indication is the first A. Next question, please.
Uh, s-
Next, please.
yeah. So next question is,
Never ever use sclerotherapy in grade 1 symptomatic hemorrhoids, grade 2 and grade 3 hemorrhoids, thrombosed hemorrhoids, patient on anticoagulants.
so I'll just end it.
Okay, we go again with the audience. Thrombosed hemorrhoids should never be injected. 80% people have responded that, but you can use the 16% have responded for anticoagulants. To just give them an answer that anticoagulants is not a contraindication for hemorrhoid sclerotherapy. The rubber band ligation is the problem when the patient is on anticoagulants because they may bleed later on. But if the patient is on anticoagulants, though of course you should try to avoid this problem, but if the patient is on anticoagulant already and is bleeding, the better is you give a sclerotherapy, which is the best agent at that time, best modality at that time.
So the next question
Next
is,
question, please.
yeah.
Yeah. Which of the following is not a sclerosant but has been used as injection in hemorrhoids? Which of the following is not a sclerosant?
I'll end it.
Okay. Yeah. Surprisingly, 28% people have told that 5% phenol in almond oil is not a sclerosant. This is the most commonly used sclerosant. Altais, I have shown you again, in Japan, it is used as a sclerosant. Sodium tetrayl sulfate can be used as a sclerosant. Yes, the micronized purified flavonoid fraction, the people have injected directly into the hemorrhoids to decrease the bleeding, but it is not a sclerosant. It has some other effect. So, out of this, MPFF is not a sclerosant. All others are sclerosants. Next question, please.
So the next question is,
Yeah. A patient of grade 2 piles got sclerotherapy done at your clinic. Second day, he complains you telephonically that he has difficulty in passing urine, there is increase in pain, and there's a rising fever. What you will do? What is the most appropriate action you will take? Response A. You will call him immediately to your clinic for examination. You will ask him to wait at home and continue the treatment given. You will counsel him, need not to come due to fear of COVID-19 spread. What will be your most appropriate action?
so I'll end it.
Okay, beautiful. 92% or 90% people have given the answer that you will call him immediately to your clinic for examination. As I've shown in my first slide of this lecture, that if you have done any of his procedure, usually the patient goes home. The problem is follow-up. And if the patient complains of any of these three, that means there can be sepsis. And you should not allow that patient to remain at home. At least you should call him for one examination. And if there is any of these problems of difficulty in passing urine, increase in pain, and rising fever, you should always examine your patient for any sign of developing sepsis. Thank you very much for participating in the quiz and for your great interactive response for that. And I will now ask Mr. Vishal to hand over the questions so that if there are any of the audience, we can answer them.
Yeah. Thank you so much, sir. Yeah, sure. Thank you so much, sir, for such a nice presentation. And
Dr. Sanjay.
Yeah.
Hello, Dr. Sanjay.
Yes.
Can I? Hello. Am I audible?
Yes.
I'm Dr. Rajiv Sharda from Bhopal.
Okay.
Okay. So I want to share my experience regarding the sclerotherapy before you end your scientific presentation. It was definitely very nice, informative, covering all the aspects of use of sclerosant agent in varicose vein as well as ganglion and in hemorrhoids. First thing regarding your question regarding the bawasir. Basically, bawasir words, I think it is coming from Unani therapy. When the piles are not bleeding, they call it as a bawasir emalia. Hello?
Okay.
Yeah. So most probably this word is generated from Unani therapy. Okay.
No. Word is from Unani therapy, okay. But why it is called bawasir? Why not any other thing? Is there any reason for that?
I don't know the reason. Because non-bleeding piles they called in Unani is a bawasir emalia, something like that. So might be possible that the word has come from the Unani.
Because in India, anything which is occurring at the bottom is bawasir. It can be fissure, it can be itching, it can be pain, it can be hemorrhoid, it can be bleeding.
Yeah.
Anything.
That's true. Everything is related with hemorrhoid patients.
Thank you, Dr. Rajiv. Thanks.
Second thing is regarding the use of, I have seen your videos that you are using Venflon as a to use sclerotherapy to inject sclerosant through Venflons. Initially, I was also using Venflon for sclerotherapy, but later on, when I find that these 24 gauge or 26 and 26 gauge scalp and sets, they are very much, scalp and sets.
Yes,
they
yes.
are comparatively good enough to give sclerotherapy, because in hand with one index finger and with the thumb of our right hand, we can very well hold this scalp pen and we can inject in a very small diameter vein also. Although we are doing the procedure USG guided, but in comparison to use of Venflon, I find that the scalp vein is much better. What is your
It's
opinion?
okay. Okay, well taken. It's okay. You can use both. No problem.
Okay. My
Okay.
third question to you regarding the maximum dose of sclerosant TDS for especially varicose vein below the knee. How much the dose you are using? Maximum dose in a one sitting.
Maximum dose, you should not increase 4 ml for sodium tetradicalcisulfate in any case. You can use it at 4 injection sites. 0.5 ml works. You can give maximum 1 ml at one site, and you should never exceed more than 4 ml as it's been told by the manufacturers of Cetrol. You should not go beyond that in
Okay.
one sitting. You can use it
Okay.
afterwards. You can use it more after, say, you can call the patient after 1 week or so again for observation, and you can
Actually, literature suggests one should not go beyond the 6 ml of TDS. Okay.
Okay, okay. By the manufacturer has written in its manual in their paper, which comes with the Citrol, that you should not exceed 4 ml, and we should honor that.
Okay.
Okay, with that, we will go to the next questions asked by other delegates.
Yes. Go for that.
Yeah. So, there is what is the role of sclerotherapy for fissure?
Sclerotherapy for fissure.
Yeah.
There is no role I have not read anywhere that giving sclerotherapy in fissure as such, because already fissure is a problem of scarring, and the chronic fissure is already scarring in the bed. And why we will give any sclerotherapy in the fissure? So there is no recommendation even by the American Society or even by the Indian Society of doing any sclerosing agent into the fissure.
Okay. There is a question from Dr. Sushil. Role of sclerotherapy in tortuous veins.
Yes, you can use it in tortuous veins. It is honestly, it is a better way, because in tortuous veins you cannot put your laser fiber. In very tortuous veins you cannot do even a radio frequency, because you have to put a guide wire and then do that. In very tortuous veins, it is better you can do a sclerotherapy agent can be given. So in tortuous veins, it basically depends upon the caliber where you want to give. So if you are not able to put a laser fiber or a radio frequency fiber or a guide wire properly, sclerotherapy is the answer.
Dr. Naval is asking, can this procedure be done without Doppler? Because there are certain instruments available, where the doctor is not required.
See, the best is if you do with a duplex ultrasound with a Doppler machine, because you can then map them properly. You can avoid any foam going away into the more proximal veins. You can see that, visualize it properly. So for a very small flare or very small little telangiectasia, you may inject, but at least you have to visualize under guidance. If you do, it will be always better.
Okay. Dr. Rajshekhar want to ask, what is the quantity of polidocanol in each pile mass?
Polidocanol in each pipe. As you have seen, that we are taking either 2 ml for all the three, or maximum 4 ml for all the three. Okay. So mean thereby 0.5 to 1 ml in one pile mass. You should not go beyond that. It's not required.
Doctor, Annada want to ask post-sclerotherapy treatment protocol. I think the question might be for hemorrhoid, I guess.
Post sclerotherapy.
Treatment protocol.
Post sclerotherapy treatment protocol for hemorrhoids, if you ask, there's nothing very specific, but you can give some metronidazole, or if the patient is immunocompromised, you should be very careful. You can add even ofloxacin, and you should ask the patient to take fiber in diet. They should not strain the stool on the stools. If there's any bleeding for 1 or 2 drops, doesn't matter. It may be taken after 2-3 days. Or if there is any secondary hemorrhage after, say, 8 days, 9 days, that there may be some ulceration, you may have to reinspect the patient. And if there is any condition, I have already told you that if there is any rising fever, or if there is any increasing pain, or if there is any urinary retention, you should be careful about the sepsis. This is for protocol for hemorrhoids. As far as sclerotherapy for veins is concerned, we are told that you have to use a compression bandage. Ask the patient for 3 days. Many people, they say for first 3 days they have all 24 hours, and after that alternately they stop doing at night. Ask the patient, they encourage them to walk, and these are general precautions, and you have to inspect the area. There may not be any extravasation. If there is any, you have to be very careful. There can be some necrosis of the skin. And again, for infection also, you can give one prophylactic antibiotic dose, and in immunocompromised patient, you should be a little more careful.
There's one more question. What are the recurrence rate of EVLA RFA?
Pardon? What is the recurrence rate of
Recurrence rate of EVLA.
EVLA? Okay. If you compare it with surgery, almost comparable, but slightly more. Recanalization was about 2% more than the surgical methods. And same is with the RFA. You have nothing much to choose between these two, but there are certain areas with RFA in a tortuosity, the RFA handling is little poor. So that's why about the recanalization is up. If you compare it with the surgery, it's comparable, hardly 2% more than the surgery, the recanalization which happens after 1 year or so.
Dr. Nawal want to ask what are the comparative results of sclerotherapy versus laser?
In
I think
where they want to ask.
that is not specified, but I guess it's varicose veins.
In varicose veins, we have already told that the recanalization was about 19% with the sclerotherapy. That's why for major truncal veins, people now reserve this EVLA. And for small perforators and small veins and residual veins, they use sclerotherapy. That is the reason. Because otherwise, 19 to 20, even 30% patient will come back if we are doing only sclerotherapy in varicose veins. As far as hemorrhoids are concerned, of course, the lasers, if you combine it with hemorrhoidal artery ligation, they have better results than sclerotherapy alone. The Alta, we don't have any experience where they claim it as 88%. We don't have any experience.
Okay. Dr. Shashikant Jadhav want to ask, can we perform endovenous ablation for LSV and foam sclerotherapy for tributary veins in the same sitting?
Yes, why not? You can do it. People do it.
Dr. Deepak Rathi want to ask, you told us that we should give metronidazole coverage after pile sclerotherapy. Is adding any anti-inflammatory agent is a wise decision?
Certain people, they add calcium dobislate also to increase the flow, because it increases the lymphatic drainage of the venous drainage in the area, as it has already been shown by the results on retina as well.
There is some connection.
I'll just call him.
I think there are some.
Yeah, sir, can you repeat the answer because there was a connectivity issue? Can you please repeat the answer?
As far as anti-inflammatory agents are concerned, people are using calcium dobislate for any treatment of hemorrhoids because it increases the lymphatic drainage, the swelling around, itching is decreased. As far as other anti-inflammatory, non-steroidal anti-inflammatory is concerned, if there is any pain, slight bit you can give, but otherwise there should not be much pain after sclerotherapy. So you can use calcium dobislate as an agent which will help in the drainage procedure, drainage of the lymphatics as well as the venous drainage after any procedure on hemorrhoids.
Okay. Dr. Dhananjay want to ask, can sclerotherapy be used in fistula?
Sclerotherapy as such and fistula. Okay. If we go by the concept of it, if you do quite well curettage of the fistula tract, and then you clean it properly, and then can you put some sclerosing agent like phenol into it, or some other plugs have been people tried. Fibrin is not that sclerosant, but phenol they have tried. Even for pilonidal sinus they have tried phenol. So that acts there as a sclerosing agent. Yes, people have tried phenol in pulmonary sinus as well as in fistula also as a sclerosing agent after you clean the fistula tract completely. But the results are not up to the mark.
Okay.
People have tried it as a sclerosing agent.
Okay. There is one more tricky question. Which is better, 5% phenol or polydiphenol or STS? Which is better?
Okay. There is only one study which I could found that out of Alta and phenol in almond oil, they have compared that the Alta was better than phenol in almond oil. I have not found any, I could not find in this limited time any study which has compared the polidocanol or STD with phenol in almond oil. And for that, probably the answer is that it is basically how you apply the sclerosing agent, which what matters, not the agent as such. But yes, with Alta, they have shown it. I have no personal experience with that, but if we compare these three, I could not find any comparative study. We can go to the literature and can find out. Personally, I have not ever studied it in this for this comparison sake that which agent is better.
Sir, that was
more important than the agent as such.
okay, sir. So, sir, that was the last question for the day. I will hand over to my marketing colleagues now for the vote of thanks.
Fine.
Yeah, thanks, Dr. Saab, for making it really meaningful and creating such a platform where I think people got the real benefit of. And we would request you in future also to be there with us in being there in this kind of platform many more times. Thanks for bringing such a clarity in handling the questions, and I'm sure that everybody got the benefit. My sincere thanks for all the participants who has attended and ensure this program to be a success, and all my colleagues for arranging this event. Thanks, Dr. Gurnath, for your insights and taking it forward in a smoother way. So with that, I think here we can close the session.
I am really grateful to and thankful to the Smart Life Sciences for giving this opportunity to share something, whatever I know I could study with my colleagues. And honestly, all benefit and all pleasure is mine. Because whenever you have to give any lecture, you have to really read it 5 times before you tell it once.
Correct,
So I'm really thankful, and I'm really to giving the concept of putting a quiz also by Mr. Bajaj. And I just made this quiz in my OPD hours today, and I handed it over to the Mr. Bajaj.
It's very nice.
And,
Very nice.
and really made it interesting for everybody, the participants also. It was something new.
Once, in fact, sir, once if you see this March, April onwards, once we all are stuck at home and because of the impact of this COVID and all, this digital forum has cropped up like anything. And nowadays, the many more events are happening, but the challenge is making it really interesting amongst those. I think very few of the such interactive sessions are of that heights where people are really getting the benefits or being or making it more interesting. So that's why we are grateful to you that you have taken the event to an height of that. So really, thank you, sir. Thanks, and thanks for all participants for being there.
Thank you so much.
Thank you.
Thank you.
Thanks for
Thank you so much.
Thank you, sir. Good night.